The mainstay of doing the stroke workup actually is to figure out what the mechanism of the stroke was, to know what the best treatment is. So, the whole point of doing the MRI, the MRA, and the TTE or TEE or whatever it is that you're doing is to figure out the mechanism of the stroke. And stroke, ischemic stroke, that is, there was a trial that was called a TOAST trial, TOAST, that categorized strokes into five categories. So cardioembolic, large artery, atherosclerotic, small vessel disease, other determined etiology, and then unknown etiology. So these are the five classifications. The most common ones being the cardioembolic, the large artery, and the small vessel disease. And really, when you think about it, the reason we do all this workup is because for cardioembolic strokes, you would have to anticoagulate them, versus for other strokes, they would usually benefit from antiplatelet therapy. So that's the rationale behind doing the workup.
Okay, so bringing us back in, you just briefly touched on what all the subcategories from the TOAST trial are. I think the first three are pretty intuitive. So the large artery, atherosclerotic events, cardioembolic, and small vessel occlusion. The part that made a little bit less, that I'm having a harder time keeping straight when I read the guidelines, the stroke of other undetermined etiology versus the stroke of undetermined etiology. What's the difference between other and then not?
So the stroke of other determined etiology. So that's where you have vasculitis and dissection and the sickle cell stroke, that kind of thing. And then the unknown etiology is, you have a 30-year-old with no vascular risk factors who comes in with a stroke. That's the kind of scenario.
Yeah, and along those lines, so keeping all those in mind, where do we start with our workup? Do we just do everything for everyone, and then what do we do? Or are there things that help you decide one thing versus the other?
So typically, all stroke patients, assuming doing a workup is going to change their management, would benefit from a brain imaging modality, MRI much more than CT. And then as far as vessel imaging, you would need some kind of vessel imaging of the head and neck. And you can use CTA head and neck or MRA head and neck, depending on your patient population and what your resources are. The next thing you need is an evaluation of the pump to those vessels, right? So you want a TTE. If you have a suspicion that the mechanism of the stroke is embolic, then you would do a TEE. Or, if you have a suspicion that the stroke is related to, for example, an endocarditis, then you would also do a TEE. Those would be the two indications for doing a TEE.
And how do you base that decision on? What makes you suspicious?
When you actually get a brain MRI, the way the strokes are distributed in the brain will give you kind of an inkling as to what the mechanism is. So if you look at a diffusion weighted image on MRI and you see strokes in multiple vascular territories, that makes you think that it's cardioembolic, because it's basically, one clot that traveled up and then showered everywhere. That would actually make me get a TEE. If a patient is young and has no vascular risk factors, I will get a TEE. Because I am hunting for the cause of the stroke. Basically, that's what it is. I am hunting for a cause of the stroke that would make me change management.
Okay. And then along all of that, frequently patients get a monitor of some kind on discharge?
Correct. So they need to be on telemetry while in the hospital. The patients that do get a monitor on discharge are the patients where we suspect an embolic etiology, but we were not able to capture AFib in the hospital. So then there's data that shows that prolonged monitoring actually increases your chances of capturing AFib.
And then just to clarify, so let's say you have the patient who comes in and very clearly it's like a large vessel occlusion, and there's nothing else like on the imaging that would suggest a cardioembolic pathway. Do you still go down that workup? I would imagine you keep them on tele like or whatnot in the hospital, but are you still going down like the TTE, TEE
Yes.
pathway?
Yep.
Yep. Okay. And that's because potentially they could have multiple etiologies that could have caused the stroke?
So, a large vessel occlusion, for the scenario of a large vessel occlusion, you're basically looking for where that clot came from. And so that's the purpose of doing, because having a large vessel occlusion by itself is actually not an indication for anticoagulating a patient with a stroke. But if you find an LV thrombus that caused that large vessel occlusion, then that's an indication. Or if you find that they have a fib and then that caused their large vessel occlusion, then that's an indication for anticoagulation. But just seeing an occlusion in a cranial vessel is actually not an indication.
Okay. If you can't tell, Moni and I sometimes struggle to get specific echocardiograms done. And so we're just trying to see if there's any reason we could skip it. But it sounds like pretty much in any scenario, you would have to get it.
Not a TEE. The TTE, it has, yes, you get in every scenario. So transthoracic echo in every scenario, and then the transesophageal echo, TEE, you would get in certain scenarios where you have a really high suspicion for an embolic etiology.
And then, and presumably with a bubble study, correct? Or
yes.
Is that?
Yep.
Okay.
Yeah, all TTEs are done with bubble study because the recommendations actually changed. The old recommendation used to be that there was no indication for PFO closure, and then there were a couple recent trials that were done that showed that there was actually a benefit for PFO closure in a subset of patients, and so that's why TTEs and stroke are always done with a bubble study.